Hello everyone, thank you for joining my presentation today. My name is Candace Alvarez, and today I will be talking to you about respiratory syncytial virus and its effect on our older adults. So what is RSV, or respiratory syncytial virus? The Mayo Clinic and the CDC define RSV as a respiratory illness that often causes mild illness, showcasing signs and symptoms typical of the common cold or mild flu. These symptoms can include, but are not limited to, congestion, runny nose, cough, sore throat, headache, all presenting with or without fever. The CDC identifies RSV as the most common cause of bronchiolitis and pneumonia in children under the age of 1. In this case, the severe RSV would lead to hospitalization. Typically, babies are the first thing that comes to someone's mind when discussing RSV. But severe illness is not exclusive to children. RSV can also lead to pneumonia and bronchiolitis in older adults. And this would present with signs and symptoms of a lower respiratory infection, which can include fever, severe cough, expiratory wheezes, shortness of breath, severe RSV is well investigated in children and is often associated with accessory muscle use, rapid, short, and shallow respirations, irritability, inconsolability, and inability to feed. Healthcare professionals caring for older adults need to use critical thinking and clinical judgment when assessing the older adult presenting with RSV. Many of the signs and symptoms typically found in infants and toddlers with RSV can also be applied to older adults. RSV was first discovered in 1956 when it was isolated from a chimpanzee held in captivity with an upper respiratory infection. RSV is an RNA virus in the Paramoxaviridae family. Other viruses within this family include the parainfluenza virus, human metapneumovirus, and measles. In September of 2016, the National Foundation for Infectious Disease released a detailed report on respiratory syncytial virus. The report disclosed that little is known about the current pathogenesis of RSV in older adults, which would lead one to wonder, after nearly 7 decades of research, how can we have no answers? Original vaccine trials began in the mid-1960s. These trials focused on immunizing children and unfortunately resulted in 2 fatalities. The children who were inoculated with the formalin inactive RSV vaccine required hospitalization, while the children in the control group did not. We know now that the vaccine had augmented the illness. Failure of this trial resulted in the adaptation of fail-fast methodology, where failure is reported immediately and trials are suspended in the event that failure is inevitable. The vaccine-augmented illness can be attributed to not having an adequate test subject. RSV is known only to humans, and the common cotton rat used to test the vaccine was not a sufficient test subject in developing the same immune response. Experts at the National Foundation for Infectious Disease, as well as CDC, agree that treatment consists mostly of supportive care, and that our best treatment plan should focus on prevention. As healthcare professionals that serve a large population of older adults, it is important to understand that several comorbidities increase a patient's chance at developing severe illness, and that severe illness can subsequently exacerbate chronic conditions. An important takeaway to share with our patients is to monitor signs for their comorbidities, specifically those related to chronic obstructive pulmonary disease, asthma, congestive heart failure, and another important thing to disclose is that adults and immunocompromised patients can shed the virus for up to 4 times longer than children. Typically, RSV is only contagious for 3 to 8 days, while adults may continue to share the virus while remaining asymptomatic for 4 weeks. Thank you for joining my short presentation on RSV in older adults.